Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is management of endometrial cancer, the current concepts. Now it is requested that you should go through the previous video of endometrial cancer, FIGO staging 2023 made easy, so that you will find the present video more useful and you will understand it better. Bachmann's hypothesis was introduced in 1983, and he introduced the concept that there are two distinct pathogenic types of endometrial cancer, type 1 and type 2. Type 1 is seen in around 90% of the cases, whereas type 2 is less common, seen in 10%. But if we see the mortality because of endometrial cancer, this type 2 contributes to around 50% of the cases, and where the histopathology is especially serous carcinoma or clear cell carcinoma. Type 1 is estrogen dependent, seen in younger and perimenopausal women. Endometrial hyperplasia usually precedes it. Obesity is commonly seen in these women. It presents with a lower stage, lower grade, and has an overall better prognosis. And endometrioid cancer. Endometrioid is the histopathology type, which is commonly seen, and that too with a low grade. It is commonly seen with this type 1 endometrial cancer. Whereas with type 2, it is estrogen independent, seen in postmenopausal and in elderly women. It is associated with endometrial atrophy, commonly seen in Asian women and thin women. It has a higher stage and higher grade, leading to poor prognosis, and the common histopathology type is either high grade endometrial cancer or non-endometrioid type of histopathology types, which we have already seen in the previous lecture. Recent view which has emerged in last few years is dividing this endometrial cancer in type 1, type 2 is too simplistic. There are subgroups in these two types which differ in prognosis as well as need of the treatment. 2023 FIGO staging provides better to plan the surgery. That is why my request is you go through the previous video, and then only you will be able to understand better the treatment for management of endometrial cancer. Molecular study, if available, adds to the pre-operative assessment as well as it helps in treatment planning. Now, molecular diagnosis has emerged as one of the recent advances associated with carcinoma endometrium. Genetic testing for Lynch syndrome should be done for all women with carcinoma endometrium. What is Lynch syndrome? It is an autosomal dominant genetic condition, and there is increase in many cancers, out of which most common are colon and endometrium. 3% of endometrial cancers are because of Lynch syndrome. If Lynch syndrome is identified, relatives are to be tested for carrier state, and once the carriers are identified, they are advised about preventive measures or surgeries to prevent the endometrial cancer. Advantages of molecular testing are it gives better information for prognosis when combined with staging and grading. It helps in targeted treatment, though at present the treatment on the basis of molecular testing is under trial. It helps in carrier identification and treatment in carriers, so that to prevent the occurrence of disease. Screening for endometrial cancer, screening of asymptomatic general population by transvaginal sonography or endometrial sampling is not recommended. Whenever we have a woman with Lynch syndrome, then transvaginal sonography, hysteroscopy or endometrial sampling should be done, and it should be initiated after the age of 35 years, because it is seen that in these women occurrence of endometrial cancer is at earlier age. We should explain limitations of screening to the women. Preventive hysterectomy with bilateral salpingoophorectomy is indicated after completion of family. Women who are on tamoxifen, no screening is indicated in asymptomatic. What we need to keep in mind is transvaginal sonography in women who are on tamoxifen has high false positives at ET greater than 10 millimeter because of subepithelial stromal hypertrophy. So it gives a false positive result of a thickened endometrium in the absence of any or typical hyperplasia or even carcinoma endometrium. That we need to keep in mind. Whenever a patient comes with bleeding or any other symptom, then it is an indication to extensively investigate the woman on tamoxifen. But in asymptomatic women, there is no place of screening is the latest recommendation. Now, how should we assess the patient suspected to having endometrial cancer in preoperative and intraoperative period? Histopathology type and grade of the biopsy specimen is most important, and preferably it should be reported by an experienced histopathologist who is experienced in field of gynec oncology. CA 125 has place only when the histopathology type shows it is a serous endometrial carcinoma. Molecular study of the biopsy is indicated in all cases whenever it is available and if it is feasible. Preoperative transvaginal sonography and other imaging modalities are to be used, and risk stratification is to be done preoperatively as per probable 2023 staging. Accordingly, plan of surgery is be done. Frozen section for myometrial invasion is not recommended currently by European guidelines, though it has been still mentioned in the American guidelines. Now, how we should go ahead with the imaging in endometrial cancer? Apart from sonography, ultrasonography, transvaginal sonography, or transrectal ultrasonography, there is no role of CT scan or MRI in suspected stage 1A. Stage 1A is whenever it is limited to especially endometrium or to the polyp as stage 1A1. Stage 1A2 is when the invasion is less than 50%, and A3 is when there is a simultaneous presence of tumor in endometrium and ovary. But in all these cases, it is a non-aggressive tumor and there is no extensive lymphovascular space invasion. So if you are asked, what I mean to say is, staging should be at the tip of the tongue, and if you are asked what is stage 1A, by this time, if you can recollect and reproduce it, then it will be very much helpful for you to understand the management. Chest X-ray is sufficient in low-risk cases. MRI should be the first modality for suspected higher stage disease. CT chest, CT abdomen, CT pelvis is to be done in suspected advanced disease. PET CT is currently not recommended in cases of carcinoma endometrium. Again, I am repeating, staging FIGO 2023 has to be at the tip of the tongue. Risk group stratification is entirely based, we can entirely base it on staging. Whole management hinges on staging and this risk group stratification, and that is why my request is, again, you go back to staging and understand and try to reproduce and try to draw the diagrams also so that it goes to your heart. As I said, staging 1A, we have already seen 1A, 1, 2, 1A1, 1A2, 1A3. 1B is when it is non-aggressive tumor and invasion is greater than or equal to 50% myometrial invasion. Stage 1C is aggressive tumor. Aggressive, I will repeat, it is either endometrioid grade 3 or high grade tumor or any of the non-endometrioid tumors such as serous tumor, mucinous tumor, clear cell tumor, or any of the other types also which are rarer. Carcinosarcoma can be there. This aggressive tumor, whenever it is limited to endometrium or polyp, then it is stage 1C. Stage 2 is spread has started occurring outside. 2A is when it is spreading to cervical stroma. Extensive lymphovascular space invasion is 2B, and aggressive tumor with any degree of myometrial invasion, it is stage 2C. Stage 3 is 3A1 is spread to adnexa, A2 is spread to uterine subserosa. B1 is spread to parametrium or vagina. Stage 3, B2 is involvement of pelvic peritoneum. 3C is about the lymph node involvement. 3C1 is about pelvic lymph node involvement. 3C1 small one is micrometastasis in pelvic lymph nodes, and 3C1 small 2 is macrometastasis. Similarly, same is for para-aortic lymph nodes. Stage 4A is bladder and rectal mucosa involvement. 4B is abdominal peritoneal metastasis, and 4C is either renal or other lymph nodes or spread to various organs such as lung, liver, brain, or bone. Then, as we have already seen in the last class, molecular classification can change the stage in early stage disease such as in stage 1 or stage 2. Now, how the risk stratification becomes easier on the basis of 2023 FIGO staging, this I have done myself. The reason is risk stratification which has been given in the European guidelines or NICE guideline, it was given in 2021, whereas FIGO staging came in 2023. So this is not included in the risk stratification. But if we combine these two with each other, it becomes easier to understand the risk division of the disease as per the risk, that is risk stratification. Low risk is whenever it is a stage 1A endometrial cancer. Intermediate risk is with stage 1B and 1C. High intermediate is for stage 2, except in stage 2C, only endometrioid high grade is with a myometrial invasion is included. Non-endometrioid with myometrial invasion are going to high risk. That is the main difference. That this is a 2C where there is aggressive tumor with myometrial invasion. This stage is 2C. Now, aggressive tumor, either histopathology can be endometrioid grade 3 tumor or any of the non-endometrioid tumor. There is a long list. Now, if it is a endometrioid high grade tumor, then it goes to high intermediate risk. On the other hand, if it is non-endometrioid, then it is categorized to high risk. In other words, if we compare the risk is greater with non-endometrioid as compared to the high grade endometrioid tumors with myometrial invasion. In high risk, along with this non-endometrioid 2C, stage 3 as well as stage 4A and stage 4B are also included. Post-operatively, whenever there is no residual disease, that means whenever the surgery has been done and there is a complete debulking possible, then in that case it is high. If complete debulking is not possible at any stage, if it is associated with residual disease, then that becomes advanced stage or stage 4C, where we have already seen that the other lymph nodes such as renal or any other lymph node involvement, or there is the involvement of various organs then that becomes such as distant organs such as brain, lung, liver, and so on. So that is stage 4C, which is an advanced disease. So these are the main 5 categories in the risk: low risk, intermediate risk, high intermediate, high, and advanced. If we see the staging according to 2023, it is easy to remember. 1A stage is low risk, 1B, 1C is intermediate risk. All 2 are high intermediate except non-endometrioid with myometrial invasion. This come under 2C along with stage 3, stage 4A and stage 4B. Stage 4C or any stage where there is a residual disease, debulking was not possible, that comes under advanced risk. Now this risk stratification has been given because the indirectly it gives us the guideline how to plan the treatment. What treatment or whether there is a need for any additional surgical steps. For example, whether there is a need to go ahead with the lymph node staging, whether there is a need to give any adjuvant radiotherapy or chemotherapy. All these important steps in the management are based on this risk stratification or division of the cases of endometrial cancer on the basis of risk. Now, surgical management for early stage disease, stage 1 or stage 2, laparoscopy or robotic option is emerging now in the last current few years, as it has been seen that the outcome is same, survival is same, disease-free interval is same, but the post-operative morbidity is less with laparoscopy as compared to the open surgery. Robotic surgery results are also as good as results with the laparoscopic surgery. So minimally invasive surgery is preferred, which includes minimally invasive surgery includes laparoscopy as well as robotic technique. What needs to be practiced while performing this minimally invasive surgery in a case of carcinoma endometrium is no extensive morcellation to be done. There should not be any spillage of the tissue in the peritoneal cavity. If vaginal uterine removal in intact state is not possible, unless you do some volume reduction and morcellation, if you cannot remove the vagina, in that case it is better to proceed with mini laparotomy or to remove the tumor by using an endobag. Metastasis outside uterus, except lymph nodes, is a relative contraindication for minimally invasive surgery. Peritoneal fluid cytology at the start of surgery has a doubtful value, especially related to the treatment plan as well as prognosis, but it can be done. It is given that it has not a great place in the staging or in the treatment plan in cases of carcinoma endometrium as opposed to carcinoma ovary. Vaginal cup resection is not recommended as per the current guideline. There is no need to remove the vaginal cup. Now, related to the frozen section for myometrial invasion, whether we should go for that or not intraoperatively to see the extent of myometrial invasion and then accordingly to decide whether to proceed with the lymph node staging or not. Now, as per all the European guidelines, these are against this frozen section for myometrial invasion because as per those guidelines, reliability of frozen section technique to assess the myometrial invasion is very less. But if we see the American guidelines and especially in the textbook of TLearn 2019, it says that if the facilities are available, we can proceed with a frozen section for myometrial invasion. So at present, the guidelines are divided, and what you should remember is it has also got a questionable place in the frozen section to assess the myometrial invasion. It has got a questionable place in the management of carcinoma endometrium as per the current guidelines. Now, what surgery we do usually for the surgical staging of carcinoma endometrium? Now, this FIGO 2023 staging, which we have seen in the last lecture, it is surgical staging. That means it is giving us a staging and after we complete the surgery, and accordingly we can plan about the post surgical need of any adjuvant therapy. Standard surgery for carcinoma endometrium is total hysterectomy with bilateral salpingo-oophorectomy. Laparoscopy can be done as we have already seen in the last slide for early cancer. There is no evidence of spread outside uterus and there should not be, and the stage should be likely stage 1 or stage 2. Then only we can take a decision to proceed with the minimally invasive surgery. Infracolicommentectomy. Now I want students to remember this point, especially that the indication to do the infracolicommentectomy in a case of carcinoma endometrium is whenever the endometrial biopsy report shows serous, undifferentiated or carcinosarcoma, even if it is in early stage. Because what is seen in these three histopathology types is serous, undifferentiated or carcinosarcoma is there is a high possibility of having occult metastasis in the omentum. And that is the reason infracolic omentectomy is only indicated in these histopathology types. Otherwise, it is not indicated as a routine staging procedure for carcinoma endometrium. Now, lymph node staging, whether we should do for all cases, again the answer is lymph node staging should be done with no doubt. Clear indication is it should be done in intermediate high or high risk cases. Now we have that is likely stage 2, 3 or 4. In these stages, we should be proceeding with the lymph node staging, especially if it is a non-endometrioid type of tumor, then or endometrioid with a high-grade tumor, then lymph node staging needs to be done. It can be considered in low or intermediate risk cases. Low is stage 1A, intermediate is stage 1. This is stage 1A and this is intermediate is stage 1B and stage 1C. In these cases, it can be considered, means it is not mandatory, especially whenever the tumor is low grade and it is non-aggressive and it is limited to endometrium or that is stage 1A1. In these cases, we can omit this step of doing the lymph node staging. So indications for lymph node staging are, definite indication is for stage 2, 3 and 4. But for stage 1, there is a option to proceed with that, or we can even omit this step, especially if the non-aggressive tumor is there, which is limited to endometrium with no myometrial invasion. So if we look at the surgery for early stage disease, stage 1, total hysterectomy with bilateral salpingo-oophorectomy is sufficient. Stage 2, here also total hysterectomy with bilateral salpingo-oophorectomy should be done. Lymph node staging should be done. But remember that there is no need of parametrectomy, or in other words, there is no need to proceed with a radical hysterectomy even if there is a spread to the cervical stroma. And there is no need of vaginal cuff removal. So that is how the surgery for this spread to the cervix from carcinoma endometrium differs from surgery for carcinoma cervix. Now, lymph node staging, there are two methods to do that. One is systemic pelvic and para-aortic lymphadenectomy, where a surgeon proceeds with the exploring all the pelvic lymph nodes and para-aortic lymph nodes and removal of these lymph nodes. Whereas other way is to do the sentinel lymph node sampling. SLN is sentinel lymph node sampling. What is the sentinel lymph node mapping and biopsy in endometrial cancer? Sentinel lymph node is the lymph node which is the first lymph node to receive drainage or metastasis from primary tumor. This is a definition of sentinel lymph node for any malignancy, that it is the first lymph node to receive drainage or metastasis from primary tumor. If we sentinel lymph node, if we assess this for the presence or absence of metastasis, it reflects status of entire lymphatic basin. That means if it is negative, there is no need to proceed with the removal of other lymph nodes in that lymphatic basin. Sentinel lymph node sampling and this biopsy is recommended over systematic lymphadenectomy in cases of carcinoma endometrium because of less morbidity associated with sentinel lymph node sampling, especially lower leg lymphedema is a common troublesome post-operative morbidity after the systematic pelvic and para-aortic lymphadenectomy. And with the sentinel lymph node sampling, when it has a better accuracy with ultra staging of this sentinel lymph node. In other words, the pathologist will be taking much more sections from this single lymph node, and that gives a better accuracy as compared to removing a whole of the lymphatic lymph nodes in the lymphatic basin. How it is done is, now for carcinoma endometrium there is not a specific single sentinel lymph node. The sentinel lymph node changes depending on the location of the carcinoma endometrium, whether it is arising from the anterior wall of endometrium, posterior wall, corn, or whether it is arising from the lower part of uterus or upper part of uterus. Yeah, accordingly, the sentinel lymph node will keep on changing, and that is why we need to assess this, do the sentinel lymph node mapping intraoperatively. Once laparotomy or laparoscopy is started, we have to uh, separate the round ligament as near to the pelvic wall as possible. We need to go retroperitoneally. We need to first create the paravesical and pararectal spaces so that we can then visualize the sentinel lymph node if it is positive. How it is done? Technique is either blue dye is used or technetium 99 radiocolloid is used. These two can be used separately or alone or in combination. But the current guidelines says that the best way to do the sentinel lymph node mapping is by using intraoperatively fluorescent in indocyanine green dye. So it is indocyanine green is used, and then it has got a better accuracy as compared to this blue dye or technetium 99 radiocolloid, which was used previously. This dye is injected in cervix to map the sentinel lymph node. It can either be injected at two places at 9 o'clock and 3 o'clock, or some techniques also describe the injection of this dye at 4 places in the cervical tissue. Other next terminology which is commonly used while describing the surgery for the carcinoma endometrium is extrafacial hysterectomy. So what is this extrafacial and what is intrafacial hysterectomy? In extrafacial hysterectomy, cervical fascia is removed along with the uterus so as to remove lymphatics in it. That means we are not leaving the cervical fascia in body. We are specifically cautious that we remove the uterus, body of uterus, we remove the cervix, as well as we remove the cervical fascia which is covering the surface of the cervix. Now this extrafacial hysterectomy is done when hysterectomy is being done for any malignancy. Now, what is done in intrafacial technique is, so many of you consultants or even postgraduate students must have done this intrafacial technique, where what is done is, once we apply the uterine clamps, next is we want to apply the clamps over the cardinal ligament parallel to the cervix. Before that, that is after clamping the uterines, you give a transverse incision over the cervical surface, over the surface of the cervix, and then that separates the cervical fascia, which can be pushed down. So transverse incision is given over the cervix, anterior surface of the cervix, and the cervical fascia is pushed down. The advantage is it ensures that all the bladder fibers are also pushed down, so that the possibility of having a bladder injury, especially if it is a case of previous cesarean section or adhesions are there, it becomes almost negligible whenever we uh, do this technique of intrafacial hysterectomy. So advantages, it prevents the bladder injury if we go by intrafacial. Disadvantages, because fascia is now going to remain in the body, it has lymphatics which are present in it, and if tumor cells are present, then chances of recurrence will be more, and that is why what we do in cases of suspected or diagnosed malignancy is always an extrafacial technique of hysterectomy, where we see to it that fascia is also removed. Every clamp which has been applied is applied lateral to the body of uterus and cervix, so that we don't open the body of uterus or cervix inadvertently. We don't keep any amount of tissue, cervical tissue also is not left behind. So total hysterectomy with complete removal of the cervix, That is the aim whenever we are doing the extrafacial hysterectomy. So many times it is described that whenever we do this hysterectomy, for uterine clamps, we apply the clamps perpendicular to this uterus and we bounce them off the cervix. This is not done in suspected or diagnosed malignancies because it can lead to the spillage of cancer cells, and you just apply the clamp lateral to the cervix without bouncing it of the cervix. That is also one part of this technique of extrafacial hysterectomy. Once you remove the uterus and around body of the uterus along with the cervix, you inspect the vaginal edge and see to it that removal of the cervix is complete. Not a small tissue of the cervix is remaining behind. That is how there is a difference between this intrafacial and extrafacial. Intrafacial is done in benign conditions, but the recent evidence shows similar results with both techniques when done for endometrial cancer. So it is by European guidelines that they have seen by the various uh, trials that whether there is a difference in the recurrence rate or survival rate if we do extrafacial versus intrafacial, and no statistical difference was found. Now, place of ovarian preservation. We say that standard surgery for carcinoma endometrium is total hysterectomy with bilateral salpingo-oophorectomy. But there are some cases where ovarian preservation can be done. It can be done whenever the patient is a premenopausal woman and her age is less than 45 years, provided it is a stage 1A1 or stage 1A2 disease, that is non-aggressive endometrial cancer, which is low grade with less than 50% of myometrial invasion. Or it is one is when it is limited to endometrium, two is less than 50% of myometrial invasion. But it has to be an endometrioid carcinoma which is of low grade, that is grade 1 or grade 2. Now, whenever ovarian preservation is being done, salpingectomy should be done to prevent occurrence of serous ovarian cancer in future. So that you remember that even if we do ovarian preservation, bilateral salpingectomy is recommended because this origin of serous ovarian cancer is, especially high-grade serous cancer, is thought to be from the fallopian tube, and that is why prophylactic salpingectomy is indicated. Ovarian preservation is not done whenever the patient has any high risk factor for development of ovarian cancer, such as Lynch syndrome, positive family history of ovarian cancer. In this or BRCA1 positive cases, in these cases, ovarian preservation will be contraindicated. A patient is medically unfit for, say, abdominal or laparoscopic surgery, then one can try to do a vaginal hysterectomy with bilateral salpingo-oophorectomy. Patient is unfit for this also, then primary radiotherapy can be given, where there is a combination of brachytherapy with external beam radiation therapy is to be given whenever it is a high-grade tumor or there is a deep myometrial invasion. Only brachytherapy will be sufficient. This is not adjuvant radiotherapy. It is called as primary radiotherapy. So students should understand the difference in terminology. If we do surgery and then we give post-operatively additional radiotherapy, it is adjuvant radiotherapy. But whenever we are giving it as a sole treatment, then it is primary radiotherapy. Only brachytherapy can be given for low-grade disease. If patient is not fit even for surgery or radiotherapy, then, as a palliation, hormonal therapy is indicated. Place of fertility preservation in cases of carcinoma endometrium. Fertility preservation should always be done after proper counseling and explaining the benefits and risks of fertility preservation to the patient and relatives. And MRI abdomen and pelvis is mandatory to rule out presence of any uh, disease which is having a likely possibility of having a spread. It is done only if there is a atypical endometrial hyperplasia, fertility preservation, or with grade 1 endometrioid endometrial cancer limited to endometrium. Now, fertility preservation is where we are not proceeding with hysterectomy. That is uterine conservation. That is fertility preservation. So we are not doing hysterectomy. Then and patient is young patient desirous for fertility. Then in these women, the criteria which need to be fulfilled are it can be done if the histopathology report shows that it is a atypical endometrial hyperplasia, or it can be done if the histopathology report comes as endometrial cancer grade 1, which is limited to endometrial. Now, non-aggressive, again I will repeat, it is the endometrioid cancer low grade, which includes grade 1 as well as grade 2. So here, for grade 1 only, there is a possibility of fertility preservation. For grade 2, it is not indicated to proceed with the fertility preservation. That is why, though these two grades have been clubbed together to label the endometrioid cancer as non-aggressive, for fertility preservation, it is important to differentiate between the grade 1 and grade 2. Fertility preservation is not indicated if it is grade 2 endometrial cancer. Now, in these cases, hysteroscopic resection of the tumor site is preferred over endometrial biopsy. Tablet medroxyprogesterone acetate is given 400 to 600 milligrams per day, or LNG-IUS, levonorgestrel releasing intrauterine system, can be used along with progestins with or without addition of GnRH analogs. So these are the two regimes which have been given in the latest guideline, either medroxyprogesterone acetate or a combination of LNG-IUS with progestin with or without GnRH analog addition. In these cases, the hysteroscopic biopsy is to be repeated at the interval of 3 months, and it should be repeated twice. That means once after 3 months of initiation of treatment and once after 6 months of initiation of this treatment. If there is no response to this treatment and it remains persistent as either typical endometrial hyperplasia or endometrial carcinoma grade 1, then it is an indication to proceed with hysterectomy. If there is a reversal of this endometrial hyperplasia or endometrioid cancer and the report comes normal, then it is considered as a good response. In that case, 6-monthly transvaginal sonography is done. There is no need to keep on repeating the endometrial biopsy unless patient has some abnormal bleeding or features suggestive of transvaginal sonography showing a thicker endometrium suggestive of recurrence of the disease. Total hysterectomy with bilateral sulfingophorectomy should be done at the earliest after completion of her family. So this is about the fertility preservation in carcinoma endometrium. Recommendations for adjuvant therapy are based on risk group or FIGO 2023 staging. Adjuvant brachytherapy can be given, adjuvant external beam radiotherapy EBRT can be given, or adjuvant chemotherapy can be given. In low risk diseases, stage 1, A1, A2, A3, or if molecular study has been done and it shows polymutation, then also it comes under the 1AM. Polymutation is also a good prognosis disease or low risk disease. In these cases, total hysterectomy with bilateral sulfingophorectomy is a treatment which is complete for these women. There is no need to add any adjuvant therapy for all these 4. Stage 1, A1, A1 is when the non-aggressive tumor with no or focal lymphovascular space involvement is limited to endometrium. A2 is it has invaded the myometrium but invasion is less than 50%. And A3 is simultaneous presence of the tumor in the endometrium and the ovary, but both are limited to the uterus, limited to the ovary with no other metastasis, and it is unilaterally present. Capsule is intact. These are the 4 criteria. If all these 4 criteria are getting fulfilled, then in these cases, total hysterectomy with bilateral sulfingophorectomy is the complete treatment, though there is no need to add any adjuvant therapy for this low risk group. Low risk is equivalent to good prognosis disease. Intermediate risk is for stage 1B, where there is a non-aggressive tumor but with no or focal lymphovascular space involvement, but the myometrial invasion is greater than or equal to 50%, as you can see here. Or 1C is when it is a non-aggressive tumor, but it is limited to endometrium or polyp. In these cases, total hysterectomy with bilateral salpingo-oophorectomy is done. Adjuvant brachytherapy can be recommended, which prevents vaginal recurrence and improves the disease-free interval. So for 1B, 1C, this adjuvant brachytherapy. Brachytherapy is mainly vaginal brachytherapy to prevent vaginal recurrence. It can be omitted in younger women with an age less than 60 years, provided the woman is ready to come for a frequent follow-up. High intermediate risk is where it is a stage 2A. 2A is when there is a cervical stromal involvement is there, as you can see here. 2B, when extensive lymphovascular space invasion under microscope or vessel is seen, which contains tumor cell, and when the number is greater than or equal to 5 vessels, it is extensive lymphovascular space invasion, that is stage 2B. And 2C is whenever there is an aggressive tumor with any degree of myometrial invasion. And for high intermediate, it is the endometrioid cancer, which is of grade 3. And if it has myometrial invasion, then it is high intermediate risk. In high intermediate risk, total hysterectomy with bilateral salpingo-oophorectomy is to be done. Adjuvant brachytherapy should be given, but in some cases there can be consideration for external beam radiotherapy can be given, especially if lymph node staging has not been done as a part of staging. So if lymph node staging has not been done and the report comes as either 2A, 2B or 2C with endometrioid cancer, these are the cases where this external beam radiotherapy can be considered. Adjuvant chemotherapy also can be considered, especially for 2B and 2C with endometrioid cancer. So either this is the difference between the intermediate risk and high intermediate risk, that consideration can be given for external beam radiotherapy as well as adjuvant chemotherapy. High risk is whenever it is a stage 2C with non-endometrioid type, that is, for example, it is a serous cancer invading the myometrial invasion is present, it is 2C. So it is high risk. Or any type, irrespective of histopathology type or grade, if it is stage 3, stage 4A or 4B with no residual disease, it is high risk. So debulking surgery has already been done and now there is no residual disease. Then external beam radiotherapy with adjuvant chemotherapy should be given, or that is simultaneously radiotherapy and chemotherapy, or one can give it sequentially as chemotherapy followed by external beam radiotherapy, or only chemotherapy can be given. It depends on the histopathology type and it depends on the other associated risk factors which are present in the patient. So the treatment needs to be individualized in this high risk group. It will differ from one patient to other. Advanced risk is we have already done the surgery, but there is residual disease which was inoperable or which was not removed. The tumor was not removed at one or the other places, or it is stage 4C with the widespread metastasis. In these cases, it is almost like a palliation where the combination of external beam radiotherapy and brachytherapy is tried. Neoadjuvant chemotherapy is tried. Neoadjuvant is you give 2 to 3 cycles of chemotherapy first, then you sandwich radiotherapy or surgery in between, and then finish off the remaining cycles of chemotherapy. So it is chemotherapy, half chemotherapy, then radiotherapy or surgery, and then remaining half is completed. That is the difference between adjuvant and neoadjuvant. Neoadjuvant is 2 to 3 cycles of chemotherapy are given for the reduction of tumor burden. Then it is followed by either surgery if now it becomes operable, or radiotherapy, whatever is according to the patient's risk. And then after completion of this, remaining cycles of chemotherapy are completed. So especially in this advanced risk, there is a role of palliative chemotherapy or palliative radiotherapy. Palliative is where we want to improve the quality of life. That is the aim of treatment. What are the recent advances in management of carcinoma endometrium? Especially molecular or genetic testing is indicated in all cases universally. Universal post-surgery immunohistochemistry is to be done on tumor cells, followed by genetic testing. In patients with positive Lynch syndrome, genetic testing of relatives and care of carriers is also included under the recent advances. Now, this is important. Immune checkpoint inhibitors are the drugs which are being tried at present and under clinical trial. These are under clinical trial for use in advanced or recurrent endometrial cancer. So, this is a ray of hope for those patients who are having advanced disease or recurrent disease, that immune checkpoint inhibitors are being tried. What these drugs are doing is they are uh, in the body itself, there are certain immune cells which are mainly after these inhibitors are given, these are acting against the cancer cells. So that is how it leads to the it helps in the symptom relief. These are effective in two molecular subtypes, these immune checkpoint inhibitors, in MMRD and in copy number high. Copy number high is when it is P53 abnormal, that is a report, or in MMRD. So, four molecular subtypes by Cancer Genome Atlas with practical implications are good prognosis is there with polymutation, DNA polymerase epsilon catalytic subunit, that is the full form. So polymutation, that is how the report is written as polymute. It carries good prognosis. Intermediate prognosis is with MMRD, but in MMRD can be seen with Lynch syndrome spontaneously. Immune checkpoint inhibitors which stimulate the body's immune cells to identify and attack cancer cells are effective in this everybody. Given alone or with chemotherapy, and this is under clinical trial. If you get a question of recent advances in carcinoma endometrium, you must include this immune checkpoint inhibitor drugs which are being tried with good results are being seen in especially whenever this report of molecular subtype comes as mismatch repair deficient or copy number high or P53 abnormal. These immune checkpoint inhibitors are effective in these two types. Intermediate prognosis is also seen in copy number low or no specific molecular profile molecular subtype. Whereas worse prognosis, poor prognosis is when it is a P53 abnormal or copy number high. But in this, though the prognosis is poor, this emergence of this ray of hope is there that immune checkpoint inhibitors are they seem to improve the outcome. Now again the repetition, a good prognosis with polymutation, intermediate with MMRD and NSMF, and poor prognosis with P53 abnormal. Staging as per molecular classification in stage 1 or 2 with change of treatment. So stage 3 and 4, there is no change in the staging with molecular subtype. But in early stage 1 or 2, there is a change in staging if we do the molecular testing. Polymutation is a good prognosis disease, which is equivalent to 1A. So it leads to downstaging to 1AM polymutation. So if, for example, if there is a patient whose molecular study report comes as this polymutation, then the early stage disease, the staging is downstaged to or reduced to 1A. And that means there is no need of any adjuvant therapy. So it has got a major impact. If it is on the other hand P53 abnormal, it has got a poor prognosis, leads to upstaging to 2C. And it needs, definitely it needs an adjuvant radiotherapy as well as chemotherapy. To summarize the treatment at a glance, as you can see, the risk keeps on increasing, and here you can appreciate that simultaneously the adjuvant therapies also, the need also keeps on increasing. So low risk is stage 1A, where we do total hysterectomy with bilateral sulfing oophorectomy. Lymph node staging has a doubtful place, can be done or it can be omitted in very early cases, and adjuvant therapy is not needed. Intermediate is stage 1B, 1C. Again, the same surgery and lymph node this staging can be done, especially if it is a sentinel lymph node sampling, that will be better. Brachytherapy is indicated. Intermediate high is stage 2 cases with stage 2C mainly endometrioid grade 3. Here lymph node staging needs to be added to total hysterectomy with bilateral sulfing oophorectomy. Brachytherapy can be given, but lymph node staging not done, then external beam radiotherapy as well as adjuvant chemotherapy can be considered. High is 2C non-endometrioid, stage 3, stage 4A or stage 4B with no residual disease where debulking has been done. Here external beam radiotherapy as adjuvant therapy and chemotherapy is indicated. Advanced is whenever there is a residual disease or widespread metastasis where mainly there is a place for palliative treatment. These are the references. This is British Gynecological Cancer Society Uterine Cancer Guideline 2021. European guideline is also there. FIGO staging is mandatory. Please remember this staging, understand this staging so that it will help you for the risk stratification and understanding of management. And Thielens and Novak's 2019 also I have referred while preparing this lecture. Thank you so much.